Hello, everybody. I'm here. It's a pleasure to talk to my friend Shahriar Zehtabchi, who is a physician in New York, in Brooklin. He's a professor and vice chairman of academic affairs in the Department of Emergency Medicine at State University of New York in Brooklyn. And he is, as a physician in the emergency room, in the epicenter of this epidemic of COVID-19. And also he's a person of science. So he's the editor-in-chief of the site known of everybody worldwide known, the NNT. And I have the pleasure to interact with him as associate editor, and he publishes a bunch of his stuff in our journal of evidence-based healthcare evidence. So we have this partnership for maybe a year or so, and it's been very fruitful in scientific terms. And now we're going to talk about the reality and how the reality in the epicenter of the problem interacts with scientific knowledge. By the way, the review in the site, the NNT, about the important points and evidence about the important points on COVID-19 is very good in the site, and I invite everybody to read the questions and answers based on evidence. So, my friend, how are you doing there?
I am doing well. Good to be with you.
It's good to see you're healthy.
Thank you.
Okay. So, first of all, I'd like you to mention how are things at the hospital. Is it really how we see on TV, a very collapsed or desperate thing, or it's better, or do you have a sense from the news of what are you living there?
It's pretty devastating. Our institution, we are one of the busiest emergency departments in the country. So we are familiar with high acuity. We have a trauma level 1 center. So we see sick patients all the time. We are not unfamiliar with sickness and death, but still, none of us has been prepared enough for this level of devastation, this level of just misery for a lot of patients. It is on an 8-hour shift that I work, I have to pronounce 5-6 patients dead. Every inch of our hospital, every inch of the space that we have is occupied by COVID patients. And unfortunately, there's not much we can do based on what we have or what we know. There's not much to offer these patients, and that makes it even harder for us. But yes, it is unbelievable. The volume is very, very high. Constantly, the entire emergency department has turned into an ICU because we don't have enough ICU beds. We have increased the number of our beds from at Downstate. We have gone from 250 to 675, but still we are struggling.
So how are you doing in terms of respirators, ventilators? Are you using one in more than one patient?
We haven't gotten to that point yet. So, I mean, we are getting to a critical point, or at least we were getting to a critical point a few days ago. But no, we haven't gone to that point yet, and we're hoping not to get to that point.
How about health workers getting sick? A lot of people are getting sick and have to be apart and away from the job.
Unfortunately, that's the case. I mean, adding beds in the hospital is easy, but you need to be able to staff those beds. You need nurses, you need doctors, you need respiratory therapists, and we're losing our doctors and nurses to the illness. So we have a lot of our staff are getting sick and they can't work. So that has been the most challenging aspect of taking care of all these sick patients, because you're losing our staff to the illness.
Do you have the impression that the disease in a healthcare worker is worse than in the general population? Maybe because the viral load is there. Do you have this impression?
Yes, I have heard that, and that's what really worries us, because jokingly in our ER we joke that we probably breathe more coronavirus than oxygen molecules on a shift, because they are the patients are everywhere, intubated patients, people on BiPAP, and we have people in the corridors and hallways, so they are not isolated because there's not enough room. So yes, we are exposed to a huge amount of viral load.
So you may be at the peak. I know that yesterday was the day that had more deaths from all day, 700 or something deaths. So when did you guys notice it was happening? When did it start in real life?
I would say about maybe 3 weeks ago. 3 weeks ago it started, the volume started to go up significantly. We started with like a few patients a day, and then every day it went higher and higher, and within a week we were running in full capacity in the hospital. It was a very quick and fast increase in the number of patients.
Fast growing. Okay, yeah. So it was mid-March. And before that, like, let's say February, did you expect that to happen? Or it was like a surprise? In this intensity, it is intensity.
We all kind of around Chinese New Year, because of the significant number of travel that was happening in mid-January, we all knew that this could become a global problem, but unfortunately we were not prepared for it, and the rest of the country wasn't prepared for it. Nobody could expect this level of devastation.
This level, that's what I think, and maybe I'm trying to bring this reflection to Brazil, because we are not at this point, and still there are people, even from the medical community, who thinks it's not going to get much worse, and kind of make it a controversy, the importance of social distance. So I think we are at a point that some people have some kind of denial of the reality. So I ask this because I wonder if, I know that by February we knew it would arrive, but maybe not this intensity, right? So was it underestimated in terms of the way it got in reality? Was it underestimated? By the whole world, yeah.
It was definitely underestimated, and now when we look back, everybody agrees, at least in New York, that we should have been prepared, and we should have been doing what we are doing now probably in mid-January.
Yeah.
And we completely dropped the ball. We completely missed it. The denial was unbelievable, and it's unfortunately in the U.S. because of the leadership that also contributed to this, that everyone was reassured that this is nothing. By April 1st, the weather gets warm, this will go away, and that did not help the situation. And honestly, you do not want to be experiencing what we are experiencing in New York. So everybody has to take this seriously, and everybody has to be prepared. I am hoping that this doesn't spread to other places, other countries, but that would be wishful thinking.
Yeah. So you mentioned the leadership of your country, that of course it was denying, but I think it was also part of the scientific community that didn't wake up in time. Even evidence-based community and scientific community. people recognize it was a problem, but I think we all, I mean, the world, all leaders, also
Absolutely.
from the Western, underestimated, and also the medical society and scientific society kind of underestimated. So I wonder why we made this mistake, except for Nassim Nicholas Taleb and his thinking on the black swan. Everybody didn't recognize the real danger. So as an exercise, a thought exercise, why do you think the scientific community make this underestimation?
I really don't know, but I am assuming that our experience with H1N1, SARS, MERS, and other similar diseases was kind of short-lived, short time. It came and in a few weeks it was controlled, and it wasn't a big deal. So I think everyone thought that this is going to be another SARS or MERS, and it's going to be controlled soon. And then this was I believe that participated to ignoring this issue.
Yeah, I agree. And I think that our way of thinking, evidence-based med thinking and epidemiological thinking, is based on the averages, on the average of what happened before. And we do this all the time. When you say that an elderly patient has a higher risk, it's because on average, he or she has a higher risk. So I think that's a rational thing, actually. It was not irrational at that time to make this prediction. Maybe the prediction that it would not be so bad had a higher probability at that time to be right compared with the prediction it will be catastrophic, right?
That makes sense. Yeah.
There is rational, and that's the way we physicians and medical science think usually. So I remember the article from Ioannidis, right? Have you read his article, Ioannidis, John Ioannidis? No. That he brings, it was like a month ago. And he brings this perspective that the case fatality ratio was probably below 1%. And we have every year things like influenza that kills like 30 to 60,000 people. So he kind of bring the concept that it was bad, but it was not so bad. And I think there is a rationale on the way of thinking like this, because we always make predictions of the future based on the past. And you mentioned SARS, MERS, and influenza, whatever.
Yeah.
But I think there was a big lesson for us that we also have to think about the possibility of the black swan. So absolutely. In January 26, Nassim Taleb wrote an article, January 26, saying that it could be catastrophic. It was based on his fat tail distribution and that kind of thing, that where rare events over time are not so rare. And the good example was September 11 in your city again.
Right.
It was improbable, not probable, not high probable. I mean, not. It was low probability, but it happens when we take the history of humanity. So we have to be very, aware of the possibility, and maybe this episode that we are living in will teach us to be more aware of rare possibilities. But still, there was a rationale at that point. That's the way I try to, because I also made the mistake of saying it would not be a black swan. And there was a rationale there. I was not thinking like a crazy person or irresponsible. And I think that probably I had a higher probability to make it to be right, but I was not. I was wrong. And I think it was part of what everybody thought at that time. So things came wrong. Yeah. So Shahriar, how about a treatment? We've been having this discussion about hydroxychloroquine, And you wrote very well here in the NNT that there's no, those two studies are no evidence for anything, right? I mean, it's not reliable studies, but it became like a thing very important for medical community to do. Why do you think it became so popular, regardless of the presidents have said, you know, our president always emulates Donald Trump, so our president is enthusiastic about hydroxychloroquine too. But regardless of that, why it became so popular? And have you been prescribed it, or and overall, what's your perception?
You know, these are really unprecedented times. Everyone is desperate. Everyone wants to find a treatment. You know, it is. This is not like anything we have experienced in the past. So it is understandable for me that people basically grab to anything that there is a remote even possibility of working. But in my opinion, because of the scale of this problem and the number of people that are involved, this is the time that we need to rely on science and proper research methodology more than any other time. Because the worst thing that you can do is jump into a conclusion too fast based on really poorly done studies or not our randomized controlled trials, and then you introduce a treatment that doesn't work, give people false sense of security, and worse than anything else, you're just subjecting a lot of people to side effects of medications that they're taking for no benefit. And anything that we come up with, it will affect lives of millions of people. So this is the time that we have to be more diligent and more rely on science rather than, oh, today, you know, all these small studies, observational, retrospective, poorly done RCTs are published. Looks like the journals don't want to be left out, so they're publishing anything that is COVID-19 related. We see a lot of really poorly designed studies and surrogate outcomes, and that gives people a false sense of hope. And like in New York, you cannot find hydroxychloroquine anywhere because people started hoarding the medication, and then if people who need it for other reasons other than COVID-19, now they cannot find it. So I understand why people are so enthusiastic about hydroxychloroquine, but I think this is the time that we need to rely on science and be patient and allow for proper research to give us the answer, so we don't expose millions of people to unnecessary treatments and treatment that can put them at risk.
What are the things that you think are very well scientific that you have been done to treat those patients? What are the...
Well, at this point, in terms of medications, we don't have anything that's very helpful. I know there are some really good international trials are right now recruiting patients, like one on remdesivir that everybody has high hopes that it will be helpful in treatment. There are at least 6 or 7 trials on that at the moment, and we're hoping to have some of those results released by end of April. There are other treatments, none have been super, we are not optimistic on a lot of them, but we have to see. So in terms of treatment with medications, we don't really have anything for at the moment.
Specific medication, yeah, specific.
And most of our, the most serious issue that we have with COVID patients is hypoxia. They are extremely hypoxic. They have bilateral pneumonia, most of the sick patients, and they become extremely hypoxic. We have been intubating a lot of people, putting them on ventilator, but unfortunately now after this couple of weeks that we've this few weeks that we've been experiencing this, unfortunately, a lot of people who go on ventilator, they develop multi-organ failure, ARDS, and they die. So ventilators don't seem to be treating the patients or buying them time to recover. Maybe early aggressive measures to treat the hypoxia is more effective than putting them on ventilators. So this is what we have been doing, that instead of intubating patients and putting them on ventilators, we try to be more aggressive in treating hypoxia.
Oh.
Yeah, so and this needs to be studied, but this is based on our experience. Aggressive treatment of hypoxia at the beginning probably is the way to go.
Oh, this is very interesting, because people have been proposing to put in the ventilator earlier than usual, right? To avoid non-invasive ventilation and aerosol, but it's not proved yet. So
correct. I mean, it's for the safety of staff. Ventilation is better than BiPAP or CPAP, but we are beyond that point. We are in a COVID-only hospital now. Everywhere is COVID.
Yeah, I agree. And for the patient's sake, it's better to act in the rational way we usually do. We intubate when it's really, necessary, right? So it's good. It's a good position. I guess the burden of proof should be on early intubation. If it's not proved, we should keep the standard. That's maybe what you're saying.
Correct. So the answer is really, we still don't know. We don't know which one is better. Early intubation or late intubation after aggressive treatment of hypoxia. We still don't know. The only thing that we have seen is that people whom we intubate, they do poorly. So whether that's because they are, if they are very, very sick and that's why they require intubation, or intubation is not doing them any favor. I mean, intubation makes us, the doctors, feel better. The numbers look better, but whether it's life-saving for the patients or not.
It's a good point. It brings a lot of unintended consequences too, intubation or secondary infection and things like this, right? So maybe, and you mentioned in your review that from the Chinese cases, 86% of invasive ventilation patients died. 86%. So is that your impression?
That's probably the number. This is we have in the past 4-6 weeks, we probably have intubated in our institution hundreds of patients, and I can count the number of patients that have been extubated with with 2 hands.
Okay.
We don't see them recover, or the recovery maybe takes a long time, but it's for some reason the multi-organ failure, the kidneys start to shut down, the ARDS, the cardiac arrest, and the whole entire system starts to shut down.
Okay.
Very quickly.
Have you been using prognostic models? For example, when the patient is admitted, have you used a multivariate prognostic model to calculate his or her risk, like you do with the Grace score in myocardial infarction, for example? So,
right.
That.
Not really. We know that there are some prognostic tools are available. I think in Italy that there's one that is probably the most validated one given the circumstances. There's one from Italy that our partners, MD Calc, they post on their website, and people find that useful. But no, it's we are not using them. It's really hard, still very hard to predict which way the patients are going. I mean, we know that there are high-risk patients, advanced age, people with cardiovascular disease, with diabetes, they do poorly, but then we see young 30, 40-year-old healthy individuals with no medical problems, and they completely crash in a few hours after we see them.
Yeah. So have you experienced problem with accuracy of the swab, RNA, PCR test? For example, a patient with high probability being negative, low negative predictive value, have you had this sense?
Yeah, unfortunately, the test is the test that we are, the PCR test is not very sensitive. So, I mean, I assume that's one of the reasons why in the US we are not doing mass testing, because even if the test is negative, there is still 30 to 40% chance of false negative. So you give people false reassurance, and they might go and socialize with other people and transfer the infections to others. The test is not very good. The sicker the patients, the better the test. So the test has a decent sensitivity in sick patients, but in mild to moderate patients, the test is not very sensitive, and it's very, I might say, disappointing. And the mild to moderate cases are the ones that go and distribute the infection to other people's, right? Because they're walking around and they are not admitted in the hospitals. And so you want an accurate test for those people especially, and this is not the case. So the test that we have right now has a sensitivity of about maybe at best 60–70%.
So when you do the test, how long it takes to get the result?
At the beginning, when we started, it would take maybe days to a week, because it had to be done through Department of Health. I don't know if you had heard of the politics surrounding the tests. And so at the beginning, it would take a long time. Now we can get it within hours, maybe 12 hours. But still, we rely predominantly on clinical findings.
Okay. So in terms of social distance, you think it's a uniform opinion among medical doctors that it is important, the social distance and strong social distance, let's say, or is it still a controversy?
I don't think it's a subject of controversy, at least here anymore. I mean, if anything, that can save the rest of the country from experiencing what we experienced in New York, that's social distancing. So I'm hope that's the only thing that we are hoping that prevents the disaster to go the rest of the country. And in New York, we are still still believing that the social distancing will help us control this earlier than we would have without social distancing.
Yeah, it is scientifically proven by a century of observations in epidemiology of infectious disease, right, and pandemics or epidemics. So, and this is the way the science, because we as physicians, we don't think like we are not used to epidemics, so we think like a patient, right?
As a global scale.
Yeah. So people criticize mathematical models as if it was not good evidence, but for epidemics and transmission of disease, they are very, accurate and have been proven to be, not in terms of the exact number, but in terms of the idea that something serious and something has to be done, but it's been done for like a century in infectious disease.
Absolutely.
Pandemic. So I think
I can see the resistance. I mean, because this social distancing has serious economical impact, and that's why probably some other countries are hesitating to go through with this. But the economical and the economical impact of having so many people suffer from the disease definitely outweighs whatever the economical impact of social distancing is going to be.
Yeah.
my opinion.
So we are getting to the end of this conversation, and I'd like you to imagine the future from now on after this pandemic. How the world is going to be, how we are going to be in personal and professional term, what's going to be the new normal for us. Are we going to be better than before? What's your thing? If you have time to think about the future.
I haven't. I am so deeply involved in day to day taking care of patients that I haven't had the time to think about this. But my main worry is that people have short memories, and I am afraid that, you know, if and when we go back to normal, I'm hoping that people will not forget these times, and I'm hoping that we will have mechanisms in place to not get back here again, ever again. But I know maybe I'm very pessimistic.
Yeah, I tend to educate myself to be optimist. So I think we're going to learn a lot from this. And
I
I don't
hope.
know if you saw there was a TED talk of Bill Gates in 2015 that
I heard about
it's like an 8-minute talk only, and he predicted the next catastrophic event would be an viral
it.
pandemic. And so I think we are going to be more aware and maybe giving more value to our lives and relationships maybe after that.
Absolutely, absolutely. And you know, globally, I think we need to revisit the issue of climate change, because I'm
Right.
pretty sure this pandemic has something to do with climate change, and you know, there are so many things that we've gone backward in the past few years, and we have to revisit, and be more mindful of how our uh, the way of life affects the climate, and how it will affect us in return.
Okay, so it was very interesting to to live a little bit of your experience through this talk, and I'd like you to know that if you need any help, or we are rooting for this thing to pass as fast as it can, and maybe we're going to talk in a few months about how things are doing, and things will be, I'm sure it will be much better than now. So I wish
I,
you all the best. And
thank you.
I speak with a lot of admiration for people like you that is on the front and doing so good and so courageous, doing good to those patients. You are an example for us. Maybe we are in the future, you're going to be in a situation similar. So what you're doing now should be an inspiration for us. So thank you very much to talk not only about science, but to talk about your feeling during this situation. Thank you, Shahriar.
Thank you so much. Thank you for having me. We'll talk soon.
Yeah.
Take care.
Thank you. Bye.